Yes. Okay. So today, I hope I'm audible.
Yes.
Yeah. Okay. So today we're going to go a little deeper into the kind of communication that we are going to have to do in a palliative care setting. So we are going to talk about breaking bad news and we are going to talk about collusion. Uh, Next slide. Yes. Thank you. So collusion is basically when the family conspires among themselves or conspires with professionals to withhold information or to lie to the patient, right? When they don't want to tell the diagnosis to the patient or the prognosis to the patient, or they request that you should also not tell the patient about what is actually happening. It's usually well intentioned. Collusion is rare, like, I've never seen collusion done with a bad intention. It's always well intentioned. It's where basically the relatives are acting in what they believe to be the best interests of the patient. So they are trying to protect the patient from emotional harm. But what happens is this usually creates a tension when the patient wants to know the truth and the patient has a right to information and the family is saying, no, no, don't tell. And collusion it must be addressed, especially when it's hindering good quality care. It is leading to futile interventions because the patient doesn't really know that, um, doesn't really know the diagnosis or the prognosis. And it's becoming harmful to the patient, right? So let's look at how do we manage this? How do we manage such kinds of situations? We'll go step by step. Next slide. Okay. So first of all, you start by conveying to the relative that you're on their side. That's the most important thing. So you don't start by trying to convert the relatives to your side, right? So the approach should always be of empathy, of I want the best, you wanted the best for your mother, definitely. I also wanted the best for her. So let us talk about it and make plans. So that has to be the attitude and approach. Once you've done that, once they know that you're on their team, it's not you versus them, then you start exploring the family's understanding. What are their insights about the illness? What is their reasoning behind the collusion? So you establish whether they're trying to protect themselves, are they trying to protect the patient? Also recognize that they may have valid concerns about the patient's capabilities to handle such news and past behavior patterns. Right now, this is important information for you as well, because they are the ones who know the best when it comes to what kind of stress uh, is the patient able to manage, how resilient are they, uh, will they break down, will they be able to handle it, will they shut themselves out. So all these things, the important things about behavior patterns of the patient and how they take bad news, this is something that the relatives are going to know the best about. And they might have these very valid concerns, which is why they are colluding. Also, identify whether they have a correct understanding of the clinical situation in the first place. Or are they acting out of assumptions, misassumptions? Right? So that's the second thing to do. After this, the third thing that you do, Sangeet, next slide, is to reassure and to explain. Reassure that you won't walk in and impose information on the patient. Find out from the family if they've already felt adverse effects of withholding of information from the patient. What I mean by adverse effects is usually, people realize that their relatives or the doctors are not telling them something, right, which is going to make them anxious. So find out whether that's the case, whether the patient has been anxious. Has the patient been in a bargaining phase where they're making unrealistic demands about the treatment? So those kinds of adverse effects which are causing unnecessary complications for the family. So find out if that is happening. and how much has that affected the family interaction? How much is withholding the information affecting the communication and the interaction within the family? Because hiding things is not an easy thing, right? They'll have to constantly walk on eggshells sort of around the patient, make sure that people are not talking about these things when they are around them, all those things. So it must have definitely affected the family interactions also. Mm, so you first of all elicit this from them. It doesn't have to be a lecture where you tell them that, when you withhold information, this happens. They would be experiencing it already. You just have to help them realize it, or to get that insight that, withholding information is what is causing these adverse effects, and it's affecting our family dynamic altogether. And then you explain the consequences of keeping the diagnosis from the patient. You also definitely have to mention that the patient has a right to information if requested, and that you recognize that patient's right. And definitely, like I said, you are on their team. It's not you versus them. So you don't have to put them in a corner. You can offer to facilitate between the family and the patient if they are finding it difficult to talk to the patient about these issues. And if they are still unwilling, you have done all of this. You have made sure that they know you are a team. You've gone ahead and reassured, and you have explained, and you have helped them realize that withholding information is having some adverse effects, and they are still unwilling. You just get conditional permission. What that means is you just get permission to find out what the patient already knows. Okay? Not you giving information, just finding out what the patient knows about their current condition. That's it. That is if they are completely unwilling to uh, let the patient know about the diagnosis or prognosis. Next slide. Then comes our fourth step, which is basically sharing information as it becomes necessary. So once you've obtained this conditional permission, or even if they want you to tell directly without the conditional permission thing in between, you still explore the patient's understanding and you assess their wishes to know. So like I'd mentioned last time, the patient's wish for further information is something that's very important. They have a right to know, they don't have a duty to know. So there might be patients who are willing to know only up to a little point, and then after that, they don't really want to talk about those things, and that is okay in a realistic timeline. So you explore their understanding first, you assess what they wish to know. After this, you inform the family members about the patient's wishes. Mostly patients, first of all, this conditional permission that I spoke about, to find out what the patient already knows. The patient might not know it in technical terms, but intuitively, on a feeling level, they definitely will have an idea that something serious is going on. You might have seen such patients also who seem to, like, they have that feeling from within that they know something is not right, even if you haven't told them, or even if the family has not told them. So most of them will want to know what is it that's not right. When you'll inform the family members about the patient's wishes, and here is where you have to take a stand, because you've already informed them that the patient has a right to know. So if they want to know, you will have to give them the information, because it's legally binding, right? Of course, it's morally binding, but it's also legally binding. And then you share information in digestible chunks. Again, the same principles of communication that we have discussed already in the previous session, where don't avoid information overload, make it into smaller digestible chunks. And inform the family members what has been discussed with the patient, keep them in the loop so that everybody is on the same page. And of course, pitch in for clarification or explanation if required further, always have a follow. Right? So these are basically steps, so to say, in how you will deal with collusion. Occasionally, patient can also happen. So let's say, for example, it's a younger patient and he doesn't want you to tell his wife, want to put his aging mother. So these kinds of situations, and these are a little like more difficult to hear, I would say, because the patient has to give permission for a disclosure of information. But basically, the principles would still be the same. Like the steps which will follow will also still be the same. Basically, sensitive handling, exploration of reasoning, explanation about the consequences, reassurance, and offering facilitation. Fine. Next slide. Okay. And now we come to communicating bad news. So we
Sorry,
collusion,
Muktha,
let
at
us say,
time,
and
excuse me, Muktha, at times your voice is breaking. Maybe
okay.
just maybe for few minutes, do without video and see if it improves. I don't know, because it was
I'll try
fine
that.
so long.
Okay, I'll try switching off my video for some time. Okay, I hope it's better now. Just let me know if it's still a problem.
It's better now. If there's anything, I will let you know, Muktha.
Yeah,
Thank you.
Yes. Okay, yeah. So when it comes to communicating bad news, no one likes having these conversations, right? They're difficult, they're uncomfortable. And today we're going to see how we can make them a little less difficult and try and understand how our patients can react and how we can respond in these situations. See, no one likes to be the one to deliver bad news, but it's also helpful to remember our aim in doing it. That we are giving somebody a bad news, that's true, but we are doing it in the best possible way so that it facilitates understanding of the situation, which itself helps people prepare themselves mentally for what is to come and not receive a shock. And at the same time, they feel supported in their emotional response to the news because of the way we communicate it. So it is like I said, a stressful task, but sadly something that we have to do quite frequently. And let's just quickly, can you go to the next slide, Sangeet? Okay, the previous one, sorry. Yeah. Okay, so the 7 steps which we had discussed in the last session are going to be very important as a general structure or a general framework for us to proceed. So I'll just quickly review them. Sorry, I missed putting it on the slide, but I'll edit it and send it when we're sharing it with you. So to quickly review the steps, firstly was to build a relationship. Second was to open up the discussion. Third was to gather information. Then to understand the patient's perspective, after which you would start sharing information, and finally arrive at an agreement on problems and plans and close the discussion sensitively. Now you will see that these steps are being repeated to an extent in the protocols that which we'll be touching upon. So before I get into it, some of you might be wondering, do we really have to do this? Communicate bad news. Why is it important and why do we have to learn to do it? Sadly enough, like I said, Sangeet, next slide. Yeah. So sadly enough, in our professions, we have to do it quite frequently. So if we anyways have to do something stressful, why not be skilled at it? Rather than fumbling around, making it more stressful for all of us involved, right? Secondly, your patients want the truth. Thirdly, there are, of course, ethical and legal obligations to let the patient know. And most importantly, how we do this is going to affect the patient's comprehension, their satisfaction with medical care, their level of hopefulness, and of course, subsequently, their psychological adjustment. So you remember my patient from last session, not knowing was what made her anxious, distressed, unhappy with her doctors. No. So, and now again, just like there are barriers to communication, which we saw in the last session, of course, there are barriers to this difficult task of breaking the bad news. First and foremost, the one who is doing this is mostly stressed. So we will have to accept that we are going to be stressed out when we are doing this. Very obvious. If I ask one of you that you have to go tell a patient that we cannot offer any curative treatment and that the disease has reached a highly advanced stage and is progressing, how would you feel? Right? It is a stressful task to do. Studies show that the bearer of bad news experiences strong emotions like anxiety. It's a burden. And this stress makes us reluctant to break the news, especially if the patient is already in a not so good condition emotionally. Nobody would want to do it. So it's not just how it affects our patients, it's also about how it affects us. Secondly, we might feel unskilled in certain areas, like how do I handle the emotional outburst? How do I do this without taking away hope? What if I'm looked at negatively because I gave the news? So that is definitely a concern for some of us. And again, as a consequence, if we are uncomfortable in delivering bad news, chances are we may avoid discussing some points which might be distressing to the patient, or in the bargain of giving hope, might end up giving false hope and optimism. So having a strategy definitely makes things easier. It eases off stress from our shoulders as well, lessening the chance of a burnout for us. So we are learning about this as much for us as for our patients. So next slide. Okay, let's just go a little back in time, back to the 1950s, 60s, 70s. In the 1950s, doctors actually considered it inhuman, damaging to the patient to disclose bad news. Of course, that was also a time when treatment prospects for illnesses like cancer were also quite bleak. But then by the time we reached late 1970s, most physicians had become more open to telling the diagnosis to the patient. But now what had happened was patients were not really satisfied with only the diagnosis. They had more questions. They wanted additional information. They wanted to know the prognosis. They wanted to know the side effects, wanted to know how much time they realistically had in hand to live. And over the years, many studies in different parts repeatedly showed the same thing, that patients wish to know. And after this came issues of patient consent and patient autonomy, which gave a further push to openly communicating with the patient about the illness. But of course, the medical fraternity had to take into account that simply disclosing the truth without a concern for the sensitivity with which it had to be done, or neglecting the duty to support this and to help them take important decisions in the face of overwhelming emotions, could have quite an impact on the patient. So we couldn't just overcompensate for years of hiding the truth with sudden insensitive truth telling. So people working in the field have over the years tried to come up with certain protocols that we can train in and can follow in situations where they are required. Most of these are based on the underlying principles before you tell, ask. And hence we reach our first protocol, that is spikes, in the year 2000. Next slide, please. Okay. So spikes basically came up with 4 main objectives: sharing information with patient, gathering responses from them, providing vital support, and creating a plan to move forward. All right. Next slide. Okay. So spikes was proposed by Bailey and colleagues in the context of cancer in the year 2000, like I said. This is one of the most well-known protocols of breaking the bad news. Many of you might have already heard of this. It's a 6-step structure which can aid in delivering bad news to patients and families. Spikes is basically an acronym, like a short form. so each letter represents one of the steps, right? So let's look at each of them. S is basically setting. So make sure the first thing to do is to make sure that the setting is right. So make sure you're doing it in a quiet, private space. If arranging a room is not possible, at the minimum, at least make sure that the curtains around the bed are drawn. Don't do it standing somewhere in the lobby, in the corridors, in the ward, somewhere in between. Try and minimize distractions. Keep your phone on silent. Or if you're likely to get calls, let the patient know beforehand. Involve significant others and let the patient choose who they want with them. And when everyone is gathered, firstly sit down. Okay? Very important. It makes everyone as comfortable as possible. It also lets them know that you're not rushing through this and you're giving it the time and space that it deserves. And it's something important that you're going to convey. So that is all about setting. Then we move on to P, which is perception of condition or seriousness. Determine what the patient knows about the medical condition. What do they suspect? Make use of open-ended questions like we discussed last time. What do you know about your condition? What has the doctor told you? My experience is most patients, especially in advanced stages of the disease, are well aware of what's happening intuitively. So listen to their level of comprehension. And if at all there is denial in the form of wishful thinking, unrealistic expectations about treatment or the outcomes, just accept it at that stage. Do not confront right away. Next is I, which is invitation. Obtain an invitation from the patient. Ask them if they wish to know the details of the condition or treatment. Not everyone will want to know, especially those who are scared can resort to the defense mechanism of shunning information because it helps them cope. So always ask if they want to know. If they say no, accept the right to not know as well, but at the same time, do not close doors. Offer to answer questions later if they wish. And once you've obtained invitation, then you go to K, which is knowledge. So if the patient says, yes, tell me, firstly give a warning that it's a bad news. You could say something like, sorry, I have a bad news to share with you. When you're giving medical facts, like we've already discussed, use simple, non-technical language which matches the patient's comprehension and vocabulary. Consider the educational level, the socio-cultural background, their current emotional state, their age. Give information in small chunks and periodically keep checking whether they've understood. Respond to their reactions as they occur. Give any positive aspects first. Give facts accurately about treatment options, prognosis, costs, etc. And most importantly, never say there is nothing more we can do for you, because there's always something you can do to keep them as comfortable as possible, to give them psychosocial, emotional support, and for pain and symptom management. Right? And then once you've given all of this knowledge, then comes E, exploring emotions. Now, these are not actually stages occurring one after the other, right? So as you gather and then give information, you will simultaneously be taking in emotional cues as well, identifying their feelings as they are expressed. So there can be a range of emotions: silence, despair, disbelief, shock, anger, denial. Give them time to express their feelings and then respond empathetically. Don't prematurely try to calm them down. Let them let it out, basically. Offer your support, offer your solidarity through reflective, empathetic statements. So, for example, what I mean by reflective, empathetic statements is like, for example, I wish the reports were better, but we'll do our best to keep you as comfortable as we can. You're not alone. We are always here with you. And then you reach strategy and summary, where so basically, if you have a clear future plan, it is going to reduce uncertainty and anxiety for the patient. So once they have relatively calmed down, ask them if they would want to know if they're ready to discuss the possible plans of action. Again, respecting their wishes. If they do not feel up to it in that session, it's okay. Allow time to calm down and you can always come back later. when you're closing the interview, ensure that you summarize the key points. You inquire if they need any clarification, and arrange for a follow-up, right? Sangeet, next. Next. We've skipped all of this already. Next, just directly go 6 slides ahead. Yeah, okay, thanks. So that was the spikes protocol. And there are also a couple of others, but we shall only look at 2 of these, spikes and breaks. Breaks was put forth by Indian and Nepali professionals in 2010, 10 years later. And it was given by Vijay Kumar Narayanan and colleagues, published in the Indian Journal of Palliative Care. This is available online with open access. So is spikes. I also have both these papers. So if you would like to take a look at that, I can share the links for both with the PPT. Because both the original papers have wonderfully explained the protocols in quite detail. So BREAKS is again an acronym, which stands for Background, Rapport, Exploring, Announcing, Kindling, and Summarizing. Sangeet, next slide. Yeah. So background is basically knowing the context of the patient. What kind of a cultural, social milieu is the patient a part of? Their religious, financial, educational background, their coping styles. Basically, it's not enough to know the disease status of a patient before breaking the bad news. You need to have done your homework about whom are you giving the news to, so that you are better informed and also more sensitive and respectful towards the patient. At this preparatory stage, you also ensure that the physical background has been set for the conversation, just like we spoke in setting in spikes. Next slide. Second thing is rapport. So rapport is going to be very important in determining how the patient is receiving the news. So having a good rapport with the clinician would make the patient feel supported, less isolated in the face of the news. So to do this, make sure that you don't hurry or rush to tell. Ask open questions and pay attention to verbal and non-verbal cues that you're receiving. Next slide. Okay. Next is exploring what the patient knows about the condition. Like you might, go back and see that I had already mentioned that the basic principle for both these protocols is basically the same, that you ask before you tell. So figure out what the patient knows about the condition. Take your time to explore their concerns in detail. So for example, if a patient is expressing fear or uncertainty while speaking of what they know, don't jump in to reassure. Explore the causes behind the fear. Let them open up and share freely first. And after that is done, you announce. Next slide. Yeah. So just like in spikes, with a warning to prepare the patient. Keep the explanation short and easy. Don't get into elaborate, overly detailed, one-sided information giving, where you're giving jargon or stories of other patients and all of that. Don't do it at this stage. This is followed by kindling of emotions. Sangeet, next slide. Here again, you need to give adequate time and space for expression of feelings. Let them cry, let them take it out. Do not lecture or try to give false hope. Most of the times, I feel, it's kind of a selfish action on our parts, where we do it because we are uncomfortable facing the pain and the sorrow of the patient. So we shut them down. And that's very unfair and honestly very wrong on our parts. So let them take it all out. Just hold space for them to do so. Patient might at this stage ask questions. Make sure your answers are on point, truthful, and shared gently. So, like I said, on point, answers tailored to the question. Don't get into lectures or lengthy monologues. There is also a chance of differential listening happening here at the stage where the patient is selectively paying attention to what they want to hear. Yeah, so be aware and alert to that possibility and keep checking for understanding. And finally, summarize. Next slide. So, if possible, give the summary in writing. Because it is difficult to remember everything when the patient is in an emotionally overwhelmed state. Summarize all the key points, all the possible courses of action. Let them know that you're available for them if they want to share, talk, or ask anything. So encourage them to reach out, offer your availability, fix a review. Most importantly, ensure immediate patient safety. So has the patient come alone? Are they driving back? Do they have someone at home who can support them? It's not like we told and that's it, our duty is done. No. So, make sure that you are ensuring that the patient is going to be safe. So some of you might be thinking that all this is fine, it's okay. And I know the sequence of actions now that, I do this and this and this and this. But what do I actually say? So we might just go blank regarding that when the time comes. And like ma'am said, rehearsal is going to be very important, like we had said last time. Next slide. So it always, like I said, helps to do a mental rehearsal. And also this is what it would look like in practicality, right? So you would say something like, can you tell me what you already know about your disease? Okay, and let us say my patient knows that it's an advanced form of cancer. And then I go ahead with yes, and unfortunately it is progressing. And then there is going to be a pause. I'll take time to take in the cues, see how they are reacting and responding, and then go to the next bite of information. And that at this stage, we're not able to offer a cure. Again, pause, taking cues. And after that, you go to the next. So here are some possible options that you can choose from. Can I tell you about them? And proceed based on the response. Right? And like I said, end it very sensitively, very gently, so that they feel supported. So saying something like, we are always here for you. And this is not going to be such a short conversation, 2 minutes done in a session. No, it is going to take time. It is going to take repeated sittings, sometimes with patients, with families. But this is how overall it will look like, right? Next slide. And so, see, now, regardless of how well we do this and how perfectly we follow these protocols, we have to remember that however well communicated bad news is still bad news. So we need to expect certain possible intense emotional reactions from patients so that we can respond appropriately and will be prepared. The first person to try and talk about this whole process of grieving and adjusting to bad news and the upcoming consequences of the bad news was Elizabeth Kubler-Ross. Many of you might be familiar with her work on stages of grief: denial, anger, bargaining, depression, and acceptance. So we put it into, like, these are put into such clear-cut stages only for ease of understanding and classification. But we need to understand that these stages are not linear. They don't necessarily come one after the other. They are fluid. And they're not prescriptive, they're descriptive. So she was only attempting to clearly describe what can happen. It doesn't mean that it's that the patient should move from denial to anger, anger to bargaining, bargaining to depression. No. So it doesn't happen in such a rigid set manner. So each of these behaviors, it's also not that, everything other than acceptance is undesirable. That is also not so. Each of these behaviors does serve a purpose and function. It is basically to keep the person safe psychologically at a given point. And these stages are needed for us to process the bad news adequately. So let us look at what are these behaviors that we're talking about. Next slide. Next one. Okay. So denial is often the first reaction to bad news. Yeah. So this can't happen. You are lying. The tests must be faulty. I want to take another opinion from a more qualified doctor. All of this is denial. Basically, the patient is trying to shield themselves from considering an upsetting, and they often reject the news or they simply avoid the topic. Um, a certain period of denial is quite normal, especially in the context of terminal illness. This could actually be quite important to process scary information without facing it in conscious awareness. But denial becomes problematic when it starts to interfere with treatment compliance. It starts delaying treatment. It minimizes symptoms. I mean, the patient starts minimizing symptoms and start insisting on curative treatment when they've been proven futile, right? Next slide. So how do we assess denial? Listen to words and observe the non-verbal cues. If you see a discrepancy between them, that's denial, right? So what I mean to say is denial is different from lack of comprehension about the state that they are in. If there is a lack of comprehension, the words will match the non-verbal cues. They wouldn't have understood. In denial, that's not the case. There is an intellectual understanding, but the emotional acceptance is what is lacking. So the words and the non-verbal cues, you will find a discrepancy. That is how you'll figure out that is denial. And how do you manage it? Firstly, like I said, ensure that it is denial, that it's not lack of information or understanding. Check the benefits and risks of denial to the patient. So the benefits will tell you why the patient is holding on to the denial. If it signals fear, like if they are minimizing symptoms and all of that, provide emotional support to deal with the fear so that the denial automatically resolves. Do not directly because it is counterproductive, and keep emphasizing your continued support. Right? Next is anger. Next slide, Sangeet. Yeah. So anger, again, commonly expressed by patients or families as they accept the bad news as reality. The anger could be turned inward or outward. It could be in the form of blaming the doctors, blaming the family, blaming God. It could also be undirected to a specific target and only coming out as irritability, short temper, less patience, etc. First of all, when we are able to recognize anger as a natural response to what is happening, then then we are basically able to not take things personally, and we'll be able to tolerate seemingly hurtful accusations and even be compassionate in the face of it because we'll realize that it's not about us. There's also this one thing that anger is, in clinical psychology, we consider anger as a tip of the iceberg. Okay, it's considered a secondary emotion where just like only the tip of the iceberg is visible above water and there is so much of it beneath. Similarly, anger is a secondary emotion, which is the emotion that's visible out, but there is so much lying underneath. So it could indicate underlying helplessness, underlying fear. So these kinds of primary emotions which are there, and we might need to target those rather than the anger. Or the anger could also be because of ineffective communication between the patient, family, and doctors. Right? So how do you manage it? Next slide. Okay. Be direct and keep it simple. First of all, ask the patient to sit down, acknowledge their emotions and name that emotion. Address that this is their need to be understood. Yeah. So what I mean by all of this is saying something like, I can see that you're really angry. Can we sit down and talk? I shall try my best to help you. Right? Recognize that the anger is at the situation, not at you, even if they're accusing you of something in their anger. Be calm, be empathetic, use positive body language, give them time to express, don't jump into justifications or explanations, observe their nonverbal cues, and acknowledge their reasons for being angry. Let's also look at what can worsen anger so that we don't do those things. Next slide. Being defensive will worsen anger. Indifference will worsen anger. If you're being dismissive about their anger, or you are blaming the patient in return, like the patient is blaming you, that is definitely going to escalate the situation. And blocking the patient, so leaving them feeling unheard. And by that, I also mean it also includes premature reassurance, because that is also going to block the patient, right? So all these things can worsen anger. So we need to avoid these things. Next slide. Okay. Next thing is bargaining, the next stage, right? Where, see, basically it is the patient trying to have some amount of control over their condition. So they start negotiating about treatment adherence or about accepting help from others, or even something like if they feel guilty about something, let us say. So they could say, okay, I'll give you an example. So if you hear a patient saying, I treated my wife badly, God, I promise I'll be a better husband if you cure me, that's bargaining. Okay, so you don't need to repeatedly correct it, but definitely do not participate actively in it, because that can be misleading about how much is actually in your or the patient's hands. So that about bargaining. And then there is depression, very obvious, most easily recognizable, probably all the previous stages or behaviors are an unconscious effort to protect oneself, or I mean, to protect the patient from the emotional pain that comes in the depression stage. Right? Next slide. And the last thing that can happen is acceptance, where they are not struggling against the reality in any way. They are recognizing the reality of the diagnosis and prognosis, and they're focusing on living the most in the time that's left. And they are preparing mentally as well as practically to say goodbye and focusing on adding life to their days rather than adding days to their life. Next slide. And I like to stop with a quote here, which is basically the reason why we're doing what we're doing here in today's session. We cannot change the outcome, but we can definitely affect the journey. And I think it'll serve us well if we remember this when we are doing what we are doing as we practice palliative care. Thank you.
Thank you very much, Muktha. As you have been telling, this is, we also keep saying that this is a very sensitive situation. And your last slide has given a strong meaning why and how it can be done. So just even though it is difficult and sensitive, but we have to do it, because when they come to know the truth, and if they feel that it was not said, both even the physician will not feel good. So from both points of view, from the patient point of view and from the practicing physician point of view also, that is justice. No? So if we are not going to be feeling comfortable on a daily basis, it's not going to be good. So even though it is difficult, there are ways and means of doing it. Like we started off with the communication session telling that it's a skill. Yes, it's a skill which can be developed. How? By practicing it in certain methodical ways. Like the spikes and breaks and all, they are all giving you a pattern. See, in that pattern, main thing is that you understand all the points and then you do it in such a way that everything happens. See, sometimes you set up, find out what they know, and then come to a stage of getting to the point. But if they break down that day completely, the patient or someone starts crying, no one is in a state to do anything. So you'll have to put a full stop there. Just because the spikes route is going on, we will not be able to progress. So you have to have this in mind. Go with your patient. What, how, when, how they are. Then stop there, deal with that situation there. Then take it from there, either that day, another time, or another day. So there are so many factors in this. We give you all these protocols and things, but when it comes to reality, you have to know all this to do it. So that is the important thing there. So giving you a framework on how to deal with the situation, which is very sensitive. At the same time, we have to give, see, they are worried, they don't know what it is, but they roughly know. See, for example, someone has had some mass, some swelling. So not even say mass, so everything is important, what word you use. Some swelling, getting treatment, they came for treatment, this test, that test, then biopsy. So nowadays and all, if you say biopsy itself, they are worried. Okay. But at the same time, they know, and from today, they know that they've gone for a test which may come this way, that way, but they want it to be the way they want. See, this is all human. We are also human beings. Okay. So knowing all this, but at the same time, we have to deal with it. So that's what. So we can't be without telling, because even if you don't tell, they themselves don't know. They'll be coming into a cancer institute or biopsy result report. Then are they not? It's part of denial. So that is why very, 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 very well said is that stages, no? It may be in one order there: denial, bargaining, anger, acceptance, all different words in it. But one can go four can become two. All that can happen. Okay. But again, for you to be aware of that. But the same denial, no, is in an initial phase to open things, so that I'm trying to avoid. Denial is another way of avoiding. How long you can avoid? Sometimes you can for some time, but you will have to face the reality. Okay, so just preparing, giving information in small chunks, and they themselves would have known. So when you get to a stage, sometimes initially maybe denial, but then when you come to they themselves, I was thinking in this way because I've been coming into this hospital. Already I did this biopsy 2 times outside. One only was doubtful. Second one, there itself, it was like that. So finally, they sent me here for confirmation. So I was aware, but I was hoping for something good. They themselves will tell. Okay, so those things like that. I did check in the chat box, no specific some messages, let me read. What happens if a patient who was told about his or her diagnosis and poor prognosis, in spite of caregivers refusing to break collusion, dies by suicide afterwards? The details were given to the patient because She wanted to know and ask the physician directly and follow the protocol of bad news breaking. Okay. Now the caregivers are blaming the physician. What should have been done in this situation? And even if we decide to withhold information, what can we say to a patient who's asking you about his or her illness? So to make this whole big thing short, I'll just see basically the patient is asking you and you're asking whether we should give the information or not. And if something like, as you've said, happens, how you deal with it. Have I got it right?
Yes, ma'am.
Muktha, go ahead and then we will.
What should have we done in this situation to avoid such a suicide or such a thing?
See, ultimately, it's the patient's choice and decision here. Whether you will be always able to is different. Let Muktha, basically, how and what to do is your query, right?
Yes.
Muktha, you go ahead and then.
Okay, yeah. So I think if you would have already, I don't know whether you've had a session on the psychosocial aspects, but I think there also you'll have.
Not yet, dear. Psychosocial will be later on.
Okay. So I think that I mean there also you'll get an idea because there you'll be speaking about how to sort of look out for these signs of depression, of suicidality, of where there are these crisis situations, so that you can make sure that you are getting someone involved, maybe a psychiatrist or a clinical psychologist, someone who will be able to professionally help them in that scenario. But then again, like ma'am said, we ultimately do have to accept that we might not be able to help everyone in every situation. That's a sad reality, but that does happen at times. But I think after that, you will get a little more clarity about how to make sure that you can do your best to prevent these things from happening.
Thank you, Mukta. See, again, I'll go in a methodical way. First thing, your question was whether to tell or not to tell. Okay. See, patient has the right to know. Okay. And if the family is colliding with the patient, they will find ways and means of finding it out. For example, whenever just a fraction of time when the parents or relatives are away, they will try to get hold of the doctor. Okay. So that reveals that they want to know and they are suspecting that the family is not telling them. Okay. So there, as I said, it is the right to know from the patient's point of view. So if it was you in that position, would you like to know or not?
Yes, ma'am, but the police is no more right now. So we don't have anyone to explain our side, right? So what will we do if the bystanders, the caregivers starts blaming us?
See. That's all. Let me go in a methodical way and then we'll come to you. I'll tell everything, then you can. Okay. What it is because the patient has the right to know. So we have to convey. So there you find a little bit, like find out if it has to happen straight away or in due course of time, you would have known how every patient, every relative they are not the same. That you will know in 2 or 3 sittings itself. What type of family they are, what type of relationship they are having. Okay. And as Mukta said, in your psychosocial session, you will know there are ways and means of finding who has better relationship. Indirectly also, you need not ask. So which all will come in that session. Okay. Where good relationship exists, where unhealthy or destructive relationship or very harmful relationships exist. All that you will come to know in that psychosocial session. Okay. So that without patient telling itself, you can know. There are, as I said, as I keep telling every time, I don't want to break the charm of each session. Every session is important. So like that, so those some information you will get from psychosocial assessment also. So you can find ways and means of how to protect yourself. So in that itself, you will know there'll be one person who will have a healthy relationship, one person might be having a very harmful relationship. So at the same time, protecting that person or patient from that harmful relationship person is also our right, if as much as possible. Okay, so
Yes.
revealing the information is patient's right and it's your duty. Okay, that is step one. And to avoid harm or discomfort for patient, yourself, all that, I said from that overall psychosocial assessment and things you can. Next, your third query is, what if this happens? What if that happens? Even if you had not told, the patient might have found from someone and could have ended up in that situation. Okay, it's not that you have been the cause for it. Okay, so again, that is also patient's autonomy, dear. We saw medical ethics, patient's autonomy comes top, and there will be we saw that each the 4 pillars of autonomy, there could be dilemmas or interrelationships between autonomy and beneficence may be in trouble there. We want to do good, but patient wants to end his life for some other reason, his or her. So like that, all that they as we said, like in today's this stages of grief are this way, that way, one can become 5 can become 2. Like that only medical ethics also. See, one place autonomy overtakes beneficence. One time autonomy overtakes justice. So it's always justice comes. There's no you have to know all of them, and on a case by case basis you have to see why, what, when, how to manage for all these factors. That is why all your 20 sessions are important before you practice. So like have I clarified, Dr. Gauri? Gauri was the person, I think.
Yes,
Gauri.
Gauri.
So have I clarified your query? Are you still having anything different to ask before I go ahead with the next question in the chat box?
Oh, no.
Okay, thank you, dear. Okay, then the
Thank you
rest, somebody has asked, what if pollution aims not the patient but other relatives due to fear of insisting on definitive treatment? No, I didn't catch. What if pollution aims not the patient but other relatives due to fear of insisting on definitive treatment? Is it Raj?
Yeah, ma'am.
Can you reframe, or I didn't understand your question.
Yeah, right. For example, mother of 2 or 3 children, like terminally ill, and finally plans for a palliative care.
Who is the patient? Is the mother?
Mother. Elder son understands everything and decides for the palliative care. But the younger son is quite different, and he may definitely
he has a different idea, concept. He says, no, I want full treatment.
Yes. So that
is that what you're coming to?
Elder son says that don't reveal these things to younger son or other relatives. So if
okay, I'll just give something, and then Muktha can also. So sometimes, like you have patient and family. Again, here, patient's wish, that autonomy, keep that in front, because this elderly, terminal ill mother might have been bedbound with dementia or something for 1 year. So she's already she's become so dependent. She's dependent on everyone for everything. And everyone says, but practically everyone is not being able to be with her. She's ending up to be with the elder son. I'm just adding more things to your story. Okay. So that is the situation. The son who says everything, he is somewhere, but he may be able to provide fund or something like that. I am imagining reality to your, I'm adding stuff to your story. Okay, so in that situation, what will happen? So what again, patient has said this is what is her wish. Okay, now don't even, there'll be always, sometimes you have to find out this kith and kin, no, you can explain to some, you need not explain to everyone, because one day 2 people will come, next day 20 people can come. So what generally we do is, yes, we can tell, we will say, the family decides on one person to whom the doctor is going to speak. And then that person takes everything to the rest of the family. Okay, because all family conflicts we start to sit and solve, we have other patients to see also. Okay, so this is one method which can be used. Again, then also you can say, not that I'll say I will talk only to one son, no more. No. You can say this and then see. Like, no, they say one more, some more people want information or different. Okay, one more session you can give and explain the pros and cons of everything. And then leave. So again, because practicality, maybe the son who is looking after the mother all the time, he is also unable to do or something. The practicalities you have to say and convey. So nothing wrong in conveying, and then their internal family conflicts are solved by themselves. Okay. Muktha, anything you want to add on to that? Because we'll have to keep track on time and before we go to the case.
No, this is the same thing, ma'am. Like you said, one thing is, I had mentioned in the slides, I didn't emphasize on it, that when taking bad news also, the patient decides who they want to be with them. You know, when the doctor is telling or will, the patient is going to be there along with who else. So the patient gets to decide which of the relatives should be in the loop. Like ma'am said, you know, everybody needs to know, especially in the Indian setting when we have like big extended families, that's sometimes not ideal.
Okay. Next thing, no, the other chat box question, even after 5th line chemotherapy, there is not much response in the disease. Patient is anxious about treatment, how to handle. See, again, here you have to, one option is the oncologist and the palliative care physician as a team can talk to her or him or whatever, whoever is the patient. That, see, the disease progression, you're showing either the PET or whatever investigation has been done and whatever chemotherapy. And see, this and all, that is why we say when they start treatment itself, if the parent team speaks truth, that's what, no, again, in like in some sessions, like you have end of life care sessions and all those things, where truth telling is very important, which Muktha has been stressing in the last previous session and this session. Okay, telling truth is the most difficult thing. Speaking truth is the most difficult thing, but still speaking truth is the best. Best, safe, easy, everything I can tell. Okay, so from that point of view, maybe you have to see, again, the patient is in denial. That is why when you're telling, they're not accepting. So we have to tell, yes, we have done everything. In spite of all that, your disease progression is there. There you have to tell, maybe if you continue, it may cause more harm than benefit to him or her, which may have to be conveyed. And there is the chance where you have to tell, yes, there may not be ways of continuing on curative treatment. There are still ways of continuing on palliative care treatment. We can keep methods, we can adopt all options to keep you comfortable, pain-free, all those options. So again, it's a phase of denial. Denial to acceptance may vary from person to person and vary from different. See, from denial direct to acceptance also without bargaining, they can come. If they get to a stage where they have come to see, it is all their physical symptoms which makes the point. Sometimes the physical symptoms may be so bothering, the curative treatment only they are doing. They are not looking into the symptomatic control or symptomatic care. Unfortunate to say, I have had such bad experiences. Even like literally in the last 1 week, I have known one very close friend person who had CA, was on treatment. His pain was not managed at all. He died yesterday. Okay. So I had to struggle with the oncologist literally 10 days before to at least start him on some painkillers. See, the patient died yesterday, 10 days before he was not on painkillers. Means then you make a call. Okay, so they are forced and fixed on treatment only. I'm not blaming anyone. Who am I to blame? Because this person, I have known him so personally for last 6 years. And what happened to him, I only could fight with the palliative care team who were caring. They said, madam, what can we do if they don't refer to us? So see, exactly what you said, 5 chemotherapy done nothing. But if they had looked after, and even when this patient died last minute, they called me just when he was dying. So what state it would have been for me. So the same state only happens to many. Why am I giving you all examples of reality? That you have to understand and see how the integration has to happen. Okay, so that is why, not that I am not blaming. Who am I to blame? All our efforts are to make sure that the patient gets some benefit. Okay, if someone is going to die, should he not get pain relief till the last breath? Why should he be denied? Before, like 3 months ago, when I had the opportunity to give whatever medications, I gave. See, when he got to a stage where only morphine was needed, I cannot buy and give morphine. Okay, other things, whatever possible, maybe I could buy and give. This I couldn't. So my hands were tied, and I couldn't help in any way. So that's why. So like that, if you tell this patient, okay, curative treatment is not being helpful for you, but palliative care also. Only thing is, you have to give some time to sit and talk to them to see what is their main concern and how can I deal with it. Have I answered? Okay, now I think we can go on to the case discussion, please. Over to you, Sangeet.
Okay. Today our case presenter is Dr. Anu Ramachandran. Over to you, ma'am.
Good evening, one and all. Am I audible, ma'am?
Yes, yes, go ahead.
Okay. Next slide, please. Okay, here is a patient. She's 41-year-old. And the diagnosis is second primary tumor. She's a known case of breast cancer, and she had squamous cell carcinoma in gingiva. She had reported to my department with a complaint of a gum infection behind her upper front teeth since 1 month, and which was increasing in size. And she's a known case of breast cancer. She said this growth is there in front of her teeth and behind her upper front teeth since approximately 1 month. Occasional pain associated since there was a progressive increase in size and bleeding present while brushing and chewing of food. So she reported to the department. Recently, there was 3 weeks back, she had a radiating leg pain for which she underwent various investigations also. So past medical history, she's a diagnosed case, carcinoma right breast, infiltrating duct carcinoma grade 3, and had undergone modified radical mastectomy 2 years back. Later on, she underwent 8 cycles of chemotherapy, 15 fractions of adjuvant radiotherapy. Recently, because of that leg pain, and she underwent various investigations, and she was diagnosed with disseminated metastasis and was planned for chemotherapy again. In her family history, her grandmother from the maternal side had passed away with oral cancer at the age of 50 years. Father's brother, both two brothers, one had carcinoma prostate, and another person had lung cancer. On general examination, she was thinly built, normal gait. There were some multiple scalp lesions which were visible, which were scaly. Her supraclavicular node was palpable. Intraorally, all her teeth were present. There was an ulceroproliferative growth of approximately 2 centimeters size in the nasopalatine area, extending 1 centimeter in size in the anterior gingiva of 11212, which was sessile, and surface of the growth appeared erythematous. There was midline diastema on 1121, grade 1 mobility of 1121, and very minimal gingivitis in the other areas. While occluding, we could see her that lower anterior teeth, the 3141, was seen impinging on the growth. Next slide. So, the routine investigation for the chief complaint, we did a RVG in relation to the 1121 and was advised CBCT, a small FOB, which revealed bone loss from the interdental area. So 3 weeks back, what she had undergone were her routine USG abdomen and pelvis, which revealed a hypoechoic area in the focal vascularity in liver. She had undergone FNAC from the supraclavicular node, which was positive for malignancy, and MRI lumbosacral spine, which had multiple skeletal mets, following which she underwent the PET scan, which had shown disseminated mets. So for the gingival lesion, she underwent an incisional biopsy. The report suggestive of dysplastic surface epithelium with direct invasion of connective tissue, which was suggestive of squamous cell carcinoma of gingiva. So she was referred back to her medical oncologist. Later further, she was referred from there to the head and neck oncology department. She was planned. She was they had decided on undergoing the chemotherapy for a METS and keep a palatal lesion under review. So no active intervention for the palatal lesion was done. The psychosocial aspects, she's a homemaker, mother of 2 children. She had reported with her husband to the department, and they had financial constraints also. The main concern, occasional pain, bleeding from the complaint side, difficulty in chewing food because of the impinging of the lower teeth on the lesion. And they were thinking most probably it would be a gum issue, a small gum infection, which will resolve with the dental treatment and medication. So to summarize, 41-year-old female patient reported with the husband to the department with complaint of growth on the gum, concerned probable gum infection, and finding it difficult to chew food with occasional pain and bleeding, decided to seek help. She is a diagnosed case of carcinoma right breast and undergone MRM, and she underwent the chemotherapy, 8 cycles of chemotherapy, 15 fractions of adjuvant radiotherapy. Yeah. Recently underwent the various investigations and was diagnosed with the disseminated mets and was planned again for chemotherapy. And she had a family history of cancer on both paternal and maternal side. Next slide. So intraorally completely dentate with ulceroproliferative growth and with minimal gingivitis in all the other areas. Next slide, please. So she underwent the biopsy of the lesion and was diagnosed as squamous cell carcinoma of the maxillary palatal gingiva. So she was referred back to her medical oncologist, and further from there, she was referred to head and neck oncology department. And she was planned to undergo chemotherapy for a METS and keep a palatal lesion under review. So my point was, how to communicate this bad news of a second primary tumor to the patient. One thing to the patient, to the family. And do we need to actively intervene for any second primary tumor in a patient with disseminated mets? Thank you.
Thank you very much, Dr. Anu. After attending this session, answering the queries your discussion points, how to communicate to the patient and to the family. What is your feeling? How did you feel before the session and how do you feel now? Where did you do that breaking bad news to that patient or
Yes, I did it. Actually, I called the patient. She said she wants her husband with her. I called them inside. I took them to my doctor's room. I made them sit there and I told them, you had undergone the biopsy and it doesn't look that good. There are some changes which is seen in the biopsy in the tissues. So you need to further do the treatment for that. So I'll give you two options, sort of. That's what I had informed them. But more than that, when I broke the news, what I found was the lady, the patient, she took it very calmly. They were sitting, she took it very calmly. But her husband, he was devastated. I saw her consoling her husband. That was what I was seeing. Then I gave them the option, maybe I can speak to the medical oncology team who is dealing with you, or you have an option, I can refer you directly to the head and neck oncology department. So they opted, they would prefer to go back to the medical oncologist because he's been treating them for so long. So then I rang up the medical oncologist right in front of them. I spoke to him and he said, you refer them back to me. I will take care of them from here. Then I asked them, do you want anybody to accompany you? So they said, no. I said, maybe I can send you my PG. So he said, no, not required. But here, what I found was the patient was strong, but the husband, he took it back.
Exactly. So that's why there is no. See, I'm really thankful to you that because I keep on telling more patient stories every time. See, we are not the same. What we expect and anticipate may not happen always like that. No? So the main thing is that from the session you got an idea how to break bad news.
Yes, ma'am.
And how not to do.
Yes,
so both are important, not catching the patient or family in the corridor and telling everything, because there are some etiquette and these are sensitive again and again as we keep telling. So there are some norms how to do it. So for example, many times, like as you said, if the husband breaks down, you may have to wait and then console him, make sure he's okay before you go to next stage.
Next stage, yes. I went like that only, even though I didn't know there was a protocol until I attended this section, ma'am. But now after attending, I think maybe I went the right way only somewhere.
So that's very good. But even if you had not known, so following this way is the best. And very good that you said you will send one your PG. Exactly. We have to offer everything. If they say no, that's fine. Yes. Okay, but if we had not done, then it may not be right or something like that, and those are important things. Muktha, please go. You want to add on? Please go ahead. And Sangeet, can we come out of the screen so that we can?
Yes, I think first of all, ma'am, like you said, without knowing that there is this protocol, if you could do it this well, I think after this session, you are going to be really good at breaking bad news whenever, because intuitively whatever you have done is the right thing. The kind of support that you've offered them.
Thank you, ma'am. Thanks a lot.
Exactly. So that's what always it's a good thing. And as she said, no, we will only keep on improving much good, better, best. Okay. And then the question that anything else you want to add on, Mukta?
No, ma'am. I think I mean, because after she has told what happened and how she dealt with it, I think it's much clear that.
Exactly. So that's why. So that's why I thought better to ask her in her own words. And other thing, the question in the next question, no, whether treating this, there are some oncologists also, no, Dr. Sundaram and all. Last time also he said he's an oncologist. Are you around? Are there oncologists around here who? Just checking if Dr. Sundaram is there. I don't think he's there. He's there, Sundaram Shanmugam. Yes,
Yes,
someone
ma'am.
also. Siddharth also. Is Dr. Siddharth also an oncologist? I mean, not getting the name properly. Siddharthani, radiation oncology. Okay. So basically, the second question, what was there in the presentation was this second primary. The second primary itself, I may be wrong. Again, I don't hesitate to accept I'm right or wrong. The second primary with so many metastases, what is the general norm and what do you do? That was your query, right, Dr. Anu? You're muted.
Yes, ma'am.
So if the oncologist can just try to help in the discussion, please.
Yes, ma'am. It's already having multiple bone mets, and it's a systemic disease.
Can
there
I know
no
who
point
is speaking? Can you tell?
Dr.
Because
Sundaram.
your video is not on.
Yeah, Dr. Sundaram.
Okay. Go ahead, please. I can. Are you a surgical or a medical oncologist?
Yeah. I am surgical oncologist. Since already there's metastatic disease in the form of multiple bone mets, we usually do not treat the second primary unless it is causing some pain or anything to be palliative. So in that case, we can give RT to that particular area where it is causing pain. Other than that, we just go ahead with the breast supportive care or palliative chemotherapy.
So, like again, anything different, Dr. Siddharthani? Anything different to what, doctors? Please go ahead.
For the bone mets, we will give radiotherapy to the specific region. Other than that, we will go for second line chemotherapy for this patient.
For the second primary?
For the second primary, we will go for chemotherapy, ma'am. Chemotherapy followed by radiotherapy if necessary.
Okay, and then basically, this patient not only bone, so many tissues secondaries also were there, right? Node, supraclavicular node was also there.
Supraclavicular.
So generally, like see, whenever you call it a second primary, just naming it in different ways, the disease progression is there, right or not? Because see, this is active metastatic disease. The PET has shown as a metastatic disease, the second primary or what it is. Is that right or not? It is. The disease has progressed everywhere.
It is progressed.
Yes, ma'am.
Yes. Dr. Sundaram also. Do you all agree with that or not?
Yes,
ma'am.
So that's what basically it has turned from a non-progressive disease to a progressive disease, which I think we have to convey to the patient and everyone that the disease progression has taken place, or confined disease has become a progressive and a disseminated disease. Is that normally conveyed by the oncology team? When you get someone like this? And at that point of time, is referral to palliative care done? Should be done? Not be done? Whatever it is. Just for discussion, I'm asking. No responses? Why so? Have I asked a very difficult question? Think of the patient perspective, and then we can answer it, I think. Okay, nobody wants to answer.
And the disease progression is usually explained to the patient. That is, if there is residual or recurrence, or there is second primary, it's explained to the patient. And then if it is in our scope, we'll handle it with the second line chemo, or else if in our setting we don't have a palliative care unit, so we are unable to refer to the palliative care unit.
It is Dr. Siddharthani speaking, right?
Yes, ma'am.
Thank you very much, dear, for that. You broke the silence. I was really feeling bad. What is it? I've not asked something non-answerable question I had not asked. Thank you very much. So exactly, see, palliative care facility may not be there, but that option at least to be thought of, or referring them to a pain department for some supportive care, or that is where the need arises to think about palliative care. So depending on the load of patients you see, you will get an idea if a palliative care department will be really helpful for you. See, palliative care, recently we have been telling, it is integrating palliative care into the whole services. That's what. So it is to help each other so that the patient gets the best treatment. Okay. So that's what, as you have been telling, I think Dr. Anu's query of when it is a second primary, you look into the condition, whether what needs to be corrected. If it is, what to say, you'll correct whatever, correct the correctable. If palliative radiotherapy, palliative chemotherapy, whatever is needed and whatever can be provided for that patient to have better quality of life. So that is why I think in this condition, they thought treating the other secondaries and metastasis rather than the second primary was the decision made there. And maybe they'll see how she responds and how she is, and then take it from there.
Ma'am, actually, I did check from the notes.
Please go ahead.
I did check, and she underwent palliative chemo. After that, they gave her palliative radiotherapy, and the notes ended there. Rest, I'm not sure.
How long before did you see this patient?
This was, ma'am, in 2021.
No, but then if you they follow up whether she survived, nothing is there.
No, ma'am. The last notes ended was with her palliative radiotherapy. That is it. After that,
so no follow up, nothing after that.
No, not with me. She was following it up with the medical oncology.
So maybe the medical oncology will.
Yeah. Ma'am, I'm in the dental department. Dental.
Okay, so you don't have contact with the medical oncology.
I speak to them. That's it. But
okay. So that's what this integrating what we are telling will be helpful. See, you will also follow up patients and will give you an idea, because why all this is needed. That's why we say, no, medical decision. You see 100 patients like this, will you not get some information on that, which can be passed on as a benefit for the future patients? So that is why integrating is important, giving an overall or a all-round information. That is where it comes handy, integrating and working together. Yes. Okay, thank you very much, Dr. Anu, and thank you to everyone. I'll pass. Muktha, anything else you want to add on? Or else I'll pass it on to Sangeeta.
No, yeah, you can.
Okay, thank you. Thank you very much, Muktha, once again, for both these sessions and taking us through in such detail, because these sessions are very, very essential, because this is one of the skill which everyone, especially to be in palliative care, we need to master it and get going on it. Big thank you to you. Over to you, Sangeet.
Thank you, Muktha ma'am, for the wonderful sessions. Thank you, Radha ma'am, for facilitating the entire sessions. Thank you, Anu Ramachandran, for presenting the case also. Thank you all. Thank you. Let's see in the next sessions. Thank you. Bye.
Thank you, one and all.